So today we are going to be discussing electrolyte imbalances, and thereafter we'll have a small quiz. And to just get right into it, we're going to start with the kalemians. That is hypokalemia and hyperkalemia. Then the king of all, let's start with hyperkalemia. Hyperkalemia, by definition, there is excess potassium in the body. Okay, normal potassium levels in the body, they range between 3.5 to 5.0 milliequivalent. So anything above 5.0 is going to be hyperkalemia. What are the causes of hyperkalemia? So the most common cause of hyperkalemia is renal diseases. So for patients with CKD, that is chronic kidney disease, and the ESRD, end-stage renal diseases. Even AKI sometimes is, could predispose a patient to having hyperkalemia. Okay. The next cause is going to be, potassium supplements. Of course, if you are on potassium supplements and you exceed, you might not even have to exceed. Probably the normal potassium levels have been achieved, and you continue having these these potassium supplements, then by default you're likely to have hyperkalemia. All right. The next cause is going to be burns. Well, for patients with burns, of course, they're losing a lot of fluids. So by default, potassium might actually be so concentrated in the blood. Okay, and the other cause is crushing injuries. Let us go just right into the signs and symptoms. Before we get here, I want you to know that every time you have a patient with hyperkalemia, especially the hyperkalemia of above 6, either way, any hyperkalemia, but mostly the kalemias of above 6.0, please have this patient on an ECG. Potassium plays a very important role in the heart muscles. It aids in contractility of the heart muscles and also the general muscles in the body. Okay, so if it has this function, then it directly affects the heart. So we need to have this patient on an ECG. And when you have this patient on an ECG monitor, this is electrocardiogram monitor, these are the signs and symptoms you're going to see. Okay, in the severe cases, the patient could go into a systole, even ventricular dysarrhythmia, such as ventricular fibrillation. That is the first ECG sign. They have peaked or tented T waves, and then they have a widened QRS, a flat P wave, and a prolonged PR. Okay, don't be so scared about this. I think if you watched my previous videos when I was talking about myocardial infarction and the likes, a little bit, you might be familiar with an ECG strip. So this is a normal ECG, okay? And then this here is an ECG of a patient who has hyperkalemia. You can see the difference on the T waves, on the P wave. Besides that, these patients are going to present with hypotension. They're going to be having bradycardia. This is quite serious. They're going to be having increased bowel sounds and diarrhea, increased deep tendon reflexes as well. Muscle weakness and paralysis is also one of the signs and symptoms of hyperkalemia, but be keen because this sign and symptom is also in hypokalemia. So the only way to be sure of what you're dealing with is actually going to be blood test, okay? And of course the ECG if you're suspecting it. When it comes to management of hyperkalemia, we are aiming towards pushing the potassium back into the cells, the potassium in the blood back into the cells, because by definition it is excess potassium in the blood. Is that all right? So we are going to be using insulin to push this potassium back into the cells, insulin IV, all right? But remember also the heart has a problem, so we are going to be needing calcium gluconate to take care of the heart muscles, all right? So hand in hand, it's going to be insulin and calcium gluconate. Is that all right? So let's go to hypokalemia, and by definition it's going to be anything of potassium that is less than 3.5. But most of the signs and symptoms begin when the potassium levels are below 3. What causes hypokalemia? What causes this low potassium in the body? You're losing the potassium. So what could be the issue? You're probably vomiting. You're probably having a diarrhea. What else could be happening? Poor nutritional intake, especially foods low in potassium, it's not well covered, and then gastric sanctioning. Okay, the signs and symptoms of low potassium. As we said, the first one that is so common with hyperkalemia is muscle weakness and paresthesia, right? Or paralysis. And then these ones, unlike the hyperkalemia, they're going to have reduced tendon reflexes. And of course, definitely we are doing the ECG even on this one. Okay, so what are you going to find on the ECG? So we will have flattening or inversion of the T wave, and we might have an appearance of a U wave. The ST segment is going to be depressed, all right? We're likely to have cardiac dysarrhythmias as well on this one. So these patients are also going to have increased sensitivity to digoxin, and also, unlike in hyperkalemia we have reduced bowel movements, and then they're likely to have constipation. Okay, so we have to be very keen with these patients in hypokalemia. Why? Because with this constipation, this can actually subsequently lead to IO due to paralytic areas. In the management of hypokalemia, we are definitely giving potassium chloride. Please, if you're unsure about the route of administration and how to do it, now you'll be sure. Never ever push IV potassium in your nursing career. Never do it. Even if you're a student and somebody is actually telling you to like push the potassium, please say no. We are giving potassium chloride as an infusion in normal saline, okay, at least 500 ml of normal saline for 40 MEq. You understand me? And it's supposed to run for 4 hours. So that means if you're doing an exam and you don't find the potassium to run for 4 hours or something, just know it's 10 MEq, at least 10 MEq per hour. Just know it's an infusion, and never in your lifetime to give potassium chloride as an IV push. This patient will definitely go into cardiac arrest immediately. In fact, they don't even give you the time to resuscitate. It's gonna be a down deal, right? So in that case, let's just jump into the calcium, the calcemias. So we're gonna start with hypocalcemia and then go to hypercalcemia. Okay. Ranges of calcium in the body is 8.5 to 10.5 milligrams per deciliter. Now, when you talk about hypocalcemia, is anything below 8.5. And as we talk about hypocalcemia, I want you to put hyperphosphatemia in this one. Why? Because calcium and phosphates, they have an inverse relationship with each other in the body. So if you have an excess of one, then the other one is in deficit. You understand me? So the signs and symptoms of hypocalcemia are definitely the signs and symptoms of hyperphosphatemia. The causes of hypocalcemia are renal failure, loop cirrhotics, and hypoparathyroidism. The signs and symptoms, I'm going to start with the most examinable ones, the ones that are not going to miss in exam if they're asking you about something to do with calcium and it being low. The Trojan sign, this has to do with when you're taking the hand movement they make when you're having the blood, when you put the cuff for measuring the blood pressure, just as it is shown here. And then the vortex sign, something to do with the cheek. So I usually go like ch. So it's vortex, it's cheek. When there's that movement that they make, just as shown on this other side. And of course, we're also having these patients on the cardiac monitor because the calcium has its own role in the heart. The QT and ST segments are going to be prolonged. These patients are also likely to have ventricular dysarrhythmias. They could also go into cardiac arrest. They have a risk to bleeding because remember calcium is very important in the body in the line of helping with clot formation. Diarrhea, tetany followed by couple. They have this nervous system excitability, and these patients are likely to go into convulsions. So it's important for us to manage these patients as soon as possible. probably calcium gluconate or calcium chloride. Supplementing these patients with vitamin D is key because, well, vitamin D aids in absorption of calcium. So let's dive into hypercalcemia. Remember that we said when we talk about hypercalcemia, think if it's hyper, then for the phosphate is hypophosphatemia. So whatever you're having as the signs and symptoms of hypercalcemia, these are going to be the exact symptoms of hypophosphatemia. And these are the causes, excessive consumption of calcium, immobility, and hyperparathyroidism. That one, yeah. A lot of calcium in the body. Like, just think about the signs and symptoms. It's like this person is so confused. The nervous system is sedated. Nothing is happening. They have this constipation thing going on. The abdomen is also distended and it's in a lot of pain. Okay. They have a lot of muscle weakness, which is also uncoordinated movements. And unlike in the hypocalcemia, now the ST segment is short. Okay. How do you manage hypercalcemia? So we are going to give biphosphonates. That is going to be the first line, of course. And eventually we might need to remove the hyperactive gland, because we said one of the causes is hyperparathyroidism. I got it right this time. So we are likely going to remove that gland, just in case it persists. So we're going to dive right into sodium and the normal ranges for sodium in the body. What is the normal sodium range? 135 to 145. So anything above 145 is gonna be hypernatremia, and anything below 135 is going to be hyponatremia. Okay. So of course sodium helps a lot in matters of fluid movement in the body, and we're going to start with hypernatremia. Okay. On the causes of hypernatremia, we are going to have tubal feedings with no flushes. So you just feed your patient and you don't flush. That is not okay. Remember to flush adequately with some warm water, adequate warm water. And inadequate water intake is going to cause hypernatremia, and as well as diabetes insipidus is a contributing factor to it. So on the symptoms of hypernatremia, we're going to have altered level of consciousness, tachycardia, hypertension, polydipsia, edema, low-grade fever. Notice how we didn't talk anything about the ECG, so you don't have to worry about the ECG my patient is having low sodium. Okay. And now there are 3 late signs of hypernatremia that you're supposed to be so keen on. When you get these signs, just know that your patient is likely going to code. Right, and you have to be very keen, and these are also highly examinable, so you need to know them. Is decreased muscle tone, swollen dry tongue, nausea and vomiting. Begin about these 3 signs in hypernatremia. The moment you start seeing the patient start to vomit, you're not headed in the right direction. Okay. So on the management of hypernatremia, we're going to be using hypotonic IV fluids, the likes of 0.45% normal saline, because these fluids are going to draw the sodium into them. You understand? I don't know if you get it, but that is definitely how it's going to work. So 0.45% normal saline and 5% dextrose in water. And this should be done in a careful setting, especially when the signs and symptoms are so bad. So now let's dive into hyponatremia, and these are sodium levels of below 135. So what are the causes of this? Excessive water intake, diuretics, and vomiting. Now, see how water is important. It is also okay to take it in moderation, okay, so that you don't incur, this side effect of having hyponatremia, diluting so much of your sodium. And in as much as it looks as something small, hyponatremia is not small. Those patients presents with a lot of confusion. Confusion is being caused by the increased intracranial pressure. Imagine this patient is even likely to go into convulsions or seizures, you know. They are going to have muscle cramps. They have tachycardia, and their pulse, when they have tachycardia, is actually ready. These patients are also likely to go into respiratory arrest. Again, these patients will present with nausea and vomiting. So what is the management of hyponatremia? We are going to give her a hypertonic fluid, which is an hypertonic saline, probably 3% hypertonic saline, and you're going to give it, you know, probably as an infusion. Not probably, we're going to give it as an infusion. Other doctors, if their hyponatremia is not as bad, they do 0.9 normal saline. But in severe cases, even if it's not that severe, as long as, you know, it's hypo, 3% hypertonic saline is the the fluid of choice for correcting this issue. Okay, so we are going to dive right into the magnesium issues. We're going to start with hypermagnesemia. Before we dive into it, let me mention something about chloride, okay? Because it's also an electrolyte in the body. It's the twin brother to sodium. Whatever is happening to the sodium, most likely is happening to the chloride. So whatever signs and symptoms you're having in hyponatremia, they're also the symptoms of hypochlorinemia. It's just the same thing, okay? It's not an inverse relationship like the calcium and the phosphate. This one, they go hand in hand. So that is all about the chloride. You don't have to think so much into it. And again, there are no ECG issues in the chloride and in the sodium, right? So let's dive into hypomagnesemia. In hypomagnesemia, I want you to think the opposite of what you'll be expecting in someone that is hypo. You know, someone that is, imagine somebody's sugars are low. What do you expect? That they are this weak, you know. Just imagine that the body of this patient is in hyper state, in hypomagnesemia. It's the opposite, completely opposite. They have very active bowel sounds. They have diarrhea. Like everything is just very fast. They have hyperreflexia. They have ventricular tachycardia. In fact, they have tachycardia. And you know, their rhythms sometimes go into a rhythm called torsades, the pointers. Those rhythms can even be, you know, ventricular tachycardia and ventricular fibrillation. Okay, Nas Mike loves putting it like this, like it's a new sheriff in town. So everything is, you know, law and order, like we are doing everything really, really fast. So they're even going to have nystagmus. And remember, the torsades, the pointers is so characteristic of hypomagnesemia. That is the only rhythm that is so characteristic of it. All right. They're having increased neuromuscular activity. They're having dysphagia. They are confused and depressed. Like there's any sign and symptom that is on the higher end, just attributed to hypomagnesemia. All right. As compared to hypermagnesemia. Is that okay? And remember, the only way to correct hypomagnesemia is by giving IV magnesium sulfate. And sometimes they won't ask you that directly. They're going to give you that rhythm of torsades, the pointers, and then they're going to ask you the management of that particular rhythm. So you definitely know it is magnesium sulfate. Thank you. Now let's move very quickly to hypermagnesemia. In hypermagnesemia, the ranges will be above 2.1, yeah, or the normal ranges of magnesium is 1.3 to 2.1 milliequivalent. So, and of course, just as I think I didn't mention it, but you hear their ECG changes. The only electrolyte you're not supposed to be worried about is just the sodium and chloride, but also in magnesium they're going to be ECG changes. The ECG changes of this one, of the signs and symptoms, are going to be prolonged PR interval and wide QRS complex. Also, this patient, just the opposite of what was happening in hypomagnesemia, they're going to have constipation, okay? because now the bowel sounds are not active. You know, you're expecting it's hyper. No. It's going to be the reverse now. These patients have depressed cardiac output, they have depressed CNS, they have bradycardia, they have hypotension. Everything is in the low, so much in the low. Then see how patients in hypomagnesemia had this increased neuromuscular excitability. These ones, they have a lot of muscle weakness. And how do we manage hypomagnesemia? So the most common cause of hypermagnesemia is that this patient was on maybe a supplement that was rich in magnesium, in magnesium sulfate. For example, laxatives and antacids, they're so rich in that. So you want to discontinue that. And if this doesn't help correct it, then we are likely to introduce calcium to counter the effects of magnesium. And also we want to make sure that we excrete this magnesium through the urine, as much of it as possible. So we can actually give diuretics to help with this one. In severe cases, you're likely going to need dialysis. So those are among the the most common management of hypermagnesemia. So we'll dive right into some few questions. Just assess yourself, see how you perform.